on to our third presentation. So the interplay between heart failure and atrial fibrillation, the chicken or the egg, we all face it. Which one drives the other? Probably both drive each other, but the dynamic duo is going to be, the first part of the dynamic duo is going to be heading towards the stage. Jess Huston is a heart failure specialist at UPMC, and Krishna Kancharla is the EP counterpart, I should say, and both of them are going to share in this talk.
Hi, thanks for having me today. Krishna's going to make his way up and take the second half of the talk. So today we're going to talk about atrial fibrillation and heart failure. We don't have any, I don't have any disclosures. Krishna does have a couple here. Let's go through our objectives. So we want to recognize the scope and overlap of atrial fibrillation in the heart failure patient population, describe the impact of AFib on outcomes in heart failure. We'll go through rate versus rhythm, control strategies, and the application in heart failure, and then outline some treatment strategies for AFib and heart failure with outcomes in mind. So I just want to make sure we're all on the same page when we're talking about heart failure and what our definitions are. Heart failure is really the inability of the heart to meet the metabolic demands of the body. And we generally group it into two big lumps, the HFrEF, so the reduced EF patients with an LVEF less than 40%, and our HFpEF patients with an LVEF greater than or equal to 40%. Now there is a little crew in there, the mid-range EF patients, which are really those with the 40 to 50% range. They often get lumped into the LVEFs greater than 40, the HFpEF patients, but they do behave a little differently. And from an AFib standpoint, patients with AFib have a 5 times increased risk of developing heart failure over their lifetime. And really that's more of a HFpEF phenomenon. It's about twofold the development of HFrEF for these patients with AFib. Now, when we diagnose HFrEF, it's pretty easy, right? Somebody rolls in with some dyspnea, their EF is less than 40, okay, you have systolic heart failure or HFrEF. HFpEF is a little tougher. They usually have 9 ways to Sunday to be dyspneic. They have AFib, smoking history, obesity, sleep apnea. And they'll all have grade 1 diastolic dysfunction or left atrial enlargement on echo. So it's a little harder to know who is AFib, HFpEF, or who's just AFib. And Barry Borlaug's group at Mayo has created this score to try to help us diagnose these patients. They looked at about 430 patients who came in with dyspnea for invasive CPET. They found about 64% of those patients had elevated filling pressures on their invasive hemodynamics. And those with HFpEF were more likely to be older, had higher BMIs, more diabetes, more hypertension. You'll notice that when you look at these scores, they're the obvious things. You look at patients with shortness of breath and go, oh, my pretest probability of HFpEF is really high. But when you look at AFib, it's the most highest weighted part of the score. And if you look at the bottom where you have the total points and the probability of HFpEF in that patient, just having AFib has your probability well over 50%. So I think this is helpful when I have somebody referred for dyspnea. These are the kind of things I'm checking off in the back of my mind as to what I think is going on. The scope of the problem is huge. So the prevalence of AFib in heart failure and HFrEF, it's between about 30 and 50%. In your mid-range EF patients, it's going to be 30 to 60%, and your HFpEF patients is going to be closer to 40 to 65%. And on the lower half of the screen, you see some of the morbidities associated with AFib and heart failure, divided by the different types of heart failure. Really, they're all created equal. The risk of all-cause mortality, heart failure hospitalization or death, and stroke or TIA are no different between the groups of patients, which I think is a little shocking when you think about the milieu of HFpEF patients versus HFrEF patients. Similarly, survival is an issue when it comes to AFib with heart failure. So if you look at this Kaplan-Meier curve, you'll see the red lines are all patients with heart failure and atrial fibrillation divided by the different types of heart failure, and the black lines are sinus rhythm heart failure. And you see that all the patients with atrial fibrillation, regardless of their flavor of heart failure, have worse survival over time. Interestingly, I don't know if you can see this because I know it's pretty small, but of course, I'm going to go forward instead of using the laser pointing. So the dotted line in black, the sinus rhythm HFpEF, has worse mortality than the patients with HFrEF and sinus rhythm, which I think is interesting, mainly because I'm seeing a ton of these patients in clinic. Quality of life is also an issue. So the Kansas City Cardiomyopathy Questionnaire grades quality of life for patients with heart failure. And the PROMIS Physical Function Questionnaire really looks at their day-to-day function, their ADLs, the things they're able to do. This study looked at about 1,700 patients with heart failure, and really just looked at their functional status with AFib and without AFib. Patients with heart failure plus AFib had significant differences in their quality of life and their functional status compared to the patients with heart failure alone. So there's a lot of impairment of quality of life, impairment of functional status, worse survival, and a lot of morbidity with AFib and heart failure. And the question is always why, right? So you end up in this vicious cycle, we think. Say somebody starts out with atrial fibrillation, then they have a 5 times risk of getting HFpEF over the next few years. They start to develop HFpEF because they get a little bit decreased cardiac output, maybe they get a little stiffness from their sleep apnea and obesity. Then HFpEF or their hypertension drives some neurohormonal activation. They start having some left atrial dilatation, fibrosis in the left atrium, and here you go, you just set up the cycle. We know any intern can tell you the loss of left atrial kick is going to cause more shortness of breath than HFpEF. I can't tell you how many times I've been told that on rounds. But there's all kinds of different flavors and fibrosis and issues with the function of the left atrium in these patients that causes them to be short of breath after they have increased left ventricular filling pressures. And as a PH doc, this is also where you end up with quote unquote end organ dysfunction of HFpEF with pulmonary hypertension. You lose the ability of the left atrium to buffer the high pressures in the left ventricle, and you lose that reservoir. So you get conduction of the high pressures to the pulmonary artery, and over time you can get pulmonary vascular remodeling and really significant pulmonary hypertension. That also has really bad prognostic indications as well. So why not just start metoprolol and be on our way? There's a lot of reasons here, specifically in HFpEF. So if you look at the guidelines data, in about 15,000 patients with heart failure that are Medicare insured over 65 years old, you can see that on this Kaplan-Meier curve, if you have atrial fibrillation with HFpEF and you have a rhythm control strategy, there is a difference in mortality over time. Now, this isn't necessarily looking at patients that were in sinus rhythm. These are patients that are indicated as a rhythm control strategy because they had atrial fibrillation ablation, cardioversion, or antiarrhythmic treatment while they're in the hospitalization during their Get With the Guidelines enrollment. And the rate control patients are beta blockers, calcium channel blockers, and DIG. Now, we could talk all day about the confounders of this, but in the end, it does seem that sinus rhythm with HFpEF is beneficial. And from a HFrEF standpoint, we have it feels like we have a lot of drugs now, but we have very few classes of drugs that actually impact mortality in these groups of patients. This is a study looking at a meta-analysis looking at HFrEF and atrial fibrillation, and those treated with a rhythm control strategy on the left or in sinus rhythm versus those with AFib. You can see treatment with beta blockers is almost totally negated in the AFib group. So we have a class of drug, an old class of drug that's well tolerated that could give you up to a 35% reduction in mortality. And just with atrial fibrillation, you almost negate that mortality benefit that you're going to get in that patient population. So what do we do from there? You know, the age-old discussion of rate versus rhythm strategies, I'm going to kick it off just a little bit with some of the older studies, and then Dr. Kancharla is going to take over. I feel like at some point during this, and maybe because I'm not an electrophysiologist, you have to talk about AFFIRM. Now, AFFIRM, though painful, only had 5% of heart failure patients. This is a on-treatment analysis of AFFIRM, so instead of the intention to treat analysis. But what they found was that there was a signal for improved mortality in sinus rhythm. Now, it's not totally clear if being in sinus rhythm is what improves your mortality, or it's just a marker of less severe disease, but it is there. So now we've moved on to looking at heart failure and atrial fibrillation and what our treatment does. So the Hot Cafe study was a very cleverly named Polish study of about 200 patients that had about a 40% cardiomyopathy of rate. And they looked at New York Heart Association functional class with rate versus rhythm control. You can see the top is rate control, the bottom is rhythm control. There's a little bit of change over time in the treatment groups, but between groups, there was no difference in New York Heart Class Association over the course of the study. So lastly, I'll talk a little bit about the atrial fibrillation and heart failure study. So this is a study that looked at LVEF less than 35%. This is not our HFpEF groups, and symptoms of heart failure and AFib. The primary outcome was time to death. And the primary treatment with rate control was beta blockers. I didn't talk about it, but AFFIRM was a lot of digoxin, which is Not ideal in a lot of our patients. Rhythm control is primarily AFib. I just want to point out that this is a lot closer to modern GDMT than a lot of the trials I've mentioned previously, especially AFFIRM. These patients actually, they're better treated than most of the patients in our clinics, my clinic too. They're on 80% are on beta blockers. You get over 90% after getting an ACE and ARBs involved, and aldosterone antagonist about 40%. That's pretty darn good for GDMT. But if you look at the rate of patients that are in sinus in the rhythm control groups and the rate control groups over time, there's a lot of overlap. So at baseline, a little over 50% for both groups are in AFib. So that's your percent in AFib on the y-axis. Over time with follow-up visits and between visits, you can see that by the end of follow-up, for the rate control group, about 65% of patients were still in atrial fibrillation. For the rhythm control group, you have over 20% of patients that are in atrial fibrillation. So regardless of what we're doing from a rhythm control strategy, whether it be amiodarone or sotalol or dofetilide, the effectiveness and durability of our treatment has been a problem over time, especially when these therapies, have proarrhythmic qualities in patients who already have a high risk of arrhythmia. And just to finish off with the survival part of things, there was no difference in survival in these patients groups that almost ended up exactly the same at the very end with lots of atrial fibrillation. 40% of the patients in the rhythm control side were in sinus at follow-up. So it's hard to say really what sinus versus AFib does, rather than what being treated with amiodarone, dofetilide, and Takehome does in this patient population that's really high risk for arrhythmias. So from there, I'm going to turn it over to Dr. Kancharla to tell us what we actually should do in these patients.
Thank you, Dr. Huston. Good morning, everyone, and thanks for this opportunity. And thank you all for joining us. Hope you're enjoying it as much as I am enjoying. So I just want to bring our attention back to what Dr. Huston discussed regarding the atrial fibrillation and heart failure and how it affects the cardiac performance. So atrial fibrillation not only loses the atrial contribution to the filling of the ventricle in diastole, but also reduces the diastolic time because of rapid rates and also unbalanced irregularity of it. So it makes sense if we bring the patients back to sinus rhythm that all of those problems are reversed and the patients should do better. But here we are with a nice background set by Dr. Huston, that we don't see patients remaining in sinus rhythm after trying antiarrhythmic drugs shown by these trials. So I'm gonna focus in the next 3 slides on 3 different strategies that were highlighted in the trials in the last 15 years, and then summarize our strategy for the atrial fibrillation and heart failure management. So the first strategy was studied in PABA CHF trial. This trial studied pulmonary vein isolation versus biventricular pacing and AV node ablation. Patients with symptomatic drug-resistant atrial fibrillation, so that's refractory to antiarrhythmic drug therapy, with LV ejection fraction less than or equal to 40%, and NYHA class 2 or 3 heart failure were studied in this trial. The study looked at endpoints of left ventricular ejection fraction improvement, 6-minute walk test, and quality of life. In all these 3 parameters, the group with pulmonary vein isolation did better compared to biventricular pacing and AV node ablation, suggesting again that maintaining sinus rhythm is superior to leaving an atrial fibrillation and control, best rate control that's possible with the device management. The next study I want to bring our attention to is CASTLE-AF. This study randomized patients to pulmonary vein isolation as opposed to conventional therapy, and most of these patients, conventional therapy was rate control. That's over 60% of patients. The remaining had an attempt at rhythm control in the conventional arm. They have studied patients with symptomatic drug-resistant atrial fibrillation again, with EF less than or equal to 35%, with NYHA class 2 to 4 heart failure. All of them had either primary prevention or secondary prevention ICD. The study looked at outcomes of mortality and worsening heart failure hospitalizations. In both these endpoints, the pulmonary vein isolation was seen to be superior. So improved mortality and reduced heart failure admissions, along with an improvement in left ventricular ejection fraction. With this study results and also a few other studies around the same time, there have been a change in the guidelines from 2019 AHA-ACC guidelines and 2020 ESC guidelines supporting catheter ablation for the management of patients with atrial fibrillation, heart failure with reduced ejection fraction to potentially impact mortality and heart failure hospitalizations. This was given a class 2 level B recommendation in 2019 AHA guidelines and class 2A recommendation in ESC guidelines. Let's look at one more treatment strategy. And this is specific to patients who we call as permanent atrial fibrillation. Now we have given up on rhythm control because of the length of the atrial fibrillation. However, patients are still very symptomatic, have heart failure NYHA class 2 to 4. In this study, they have used narrow QRS as one of the inclusion criteria. In this study, they have randomized patients to either conventional therapy, which is rate control, versus ablation and ablation of the AV node and biventricular pacing. The study looked at endpoint as all-cause mortality. In the group that had biventricular pacing and AV node ablation did better. They had improved survival. Interestingly, when you look at the average heart rate in both arms, it's only different by 10 beats. So patients who had biventricular pacing and AV node ablation averaged around 70 beats per minute, whereas rate control arm had 82 beats per minute. Both are under our guideline heart rate recommendations, which was interesting to notice. Let's talk about the take-home points. I think the first thing to really pay our attention to is to recognize this group of patients. So once we see patients with atrial fibrillation and heart failure, this is an important group of patients with higher mortality and morbidity. And we have to really have a combined management with involving the patient's primary care physicians, our cardiology, heart failure doctors, and EP to decide on how to approach these patients. And the second take-home point is really important to recognize the risk factors that led them to have these two diagnoses together. Often these are overweight, obesity, alcohol consumption, uncontrolled hypertension, sleep apnea, and lack of exercise. And all these are important to recognize and start discussing with patients on those interventions. Guideline-directed medical therapy for heart failure and oral anticoagulation based on stroke risk score are very important to consider as the first options for these patients. Every patient in this class requires rate control. If patients are still symptomatic, the first question to ask is what is the best way to maintain sinus rhythm? And so far, the data suggests that the catheter ablation is the best available option. Some patients may require more than once. Some patients may require catheter ablation and antiarrhythmic drug therapy. But maintaining sinus rhythm should be the priority if it's practical based on the evaluation for these patients. If it's felt that patients are not good candidates for rhythm control, then it's best to consider if there is value in biventricular pacing and AV node ablation for these patients as opposed to rate control alone. So in summary, there's more data coming up. There are still more questions to be answered for this population, but there is some hope that maintaining sinus rhythm by catheter ablation seems to offer improved outcomes in this patient population. And with that, I thank you, everyone, for all your attention. Happy to answer any questions.
Thank you, Krishna, and thank you, Jess. We have time. You know, we made up time. So if anybody on the chat or in the room has any questions, maybe I can started off with some questions for you. So the acute clinical situation, the patient shows up in AFib with rapid ventricular response rate, and they are in heart failure. If, maybe both of you can weigh in on how do we tackle this patient? In a sense, do we treat the heart failure and then get to slow down the AFib? Do we tackle the AFib with a cardioversion? And then, how do those two things in real time in the acute situation play out?
Yeah, it's a really hard patient to figure out. I feel like the majority of the time, and maybe this is just the patient population I see, the majority of the time, the problem is the heart failure and not the AFib. I've been quoted as saying AFib is a fever of the heart. So if you expect somebody to be in sinus rhythm at the same rate they're in heart and AFib, then the AFib's not the problem most of the time. And the other issue is if you have somebody that's 40 pounds volume overloaded, no matter how much amio or how many cardioversions you do, until you reduce their left atrial stretch, decrease their left ventricular end diastolic pressure, you're going to have a lot of trouble durably keeping them out of AFib or rate control. So the answer is yes, all the things. Sorry. I think I tend to treat the heart failure first and treat the AFib as kind of a fever in that scenario.
Krishna,
excellent question, Samir. And just to bring a couple of points through Dr. Huston's words. So we often find these patients in this combination together. They have heart failure and atrial fibrillation. I think the key patient population to recognize is when they have one of these two diagnoses newly. So patients with heart failure now have AFib, or patients with atrial fibrillation newly having heart failure. And that's when really the outcome starts changing for these patients. And also probably the third is patients who have both, but now have worsening heart failure. This is where really the multidisciplinary care is most needed. And until the heart failure management is settled and at a balance, the atrial fibrillation options or rhythm control don't work well. This is where the combination therapy, combination management is such an important thing.
Perfect. A question online is, how do we define failure of medical therapy before we go to ablation procedures? Krishna, maybe you want to take this one.
Thank you. Excellent question again. So in the studies, they have defined this as at least one rhythm control agents, let's say, for example, amiodarone or diflunomide tried, and patients had recurrence again. In all the studies that, that were shown in the presentation. I think if we just open that up more, so let's say someone is attempted on rate control and still has symptoms. So the rates are controlled and still has symptoms, or rate control is not actually achieved. They don't have good rate control. That you can call as failure of rate control strategy. For rhythm control, either the resumption of sinus rhythm is not feasible, or the recurrence of atrial fibrillation is the case to call it as a failure.
Perfect. Another question online. How long do you anticoagulate your patients after an ablation?
Thank you again. It's a good question. It's a question also dependent upon the patient. So it's patient-based. So for patients who have no or low CHADS score, that is, let's say 1, the anticoagulation recommendations are 4 to 6 weeks after the ablation and assess for discontinuation of anticoagulation. And of course, all patients who had atrial fibrillation in the past are at high risk of having recurrence, so you continue to screen. But for patients who have higher CHADS score 2 or more, especially with heart failure, they're at higher risk of stroke than others. So at this stage, the recommendation is to continue anticoagulation even after the ablation and monitor for the recurrence.
Perfect. Just a couple of questions for you. I was surprised to hear you say, well, the digoxin, we don't care too much about it, because that's what's prevalent in the EP world. Yeah. Because we feel like it doesn't control things. But in the HFrEF population where there may be value in terms of, the contractility, what's your feeling about the digoxin, in the context of HFrEF AFib?
I very rarely use it. It's kind of my last choice because, ideally, I think you try to get these people to either AV node ablation and BIV pacing or catheter ablation. It just doesn't seem to be able to have the effect in the heart failure patients, the rate control that we really want. I very rarely start digoxin because also withdrawing it in a patient population that has kind of marginal cardiac index, I've seen patients decompensate. Also, all my patients have labile renal function, so that's always a consideration when you're giving somebody 200 of Lasix Q6 and metolazone every other day.
Perfect. Another mechanistic question, I guess, a quick one for the atrial kick. Do you think it's more important in HFpEF or HFrEF?
I think both, because both have problems with reduced preload and diastolic dysfunction. So I think it affects both. I think we see it a little bit more in the HFpEF patient population, just because, we could explain the HFrEF shortness of breath by a lot of different things we have on imaging, but HFpEF is very nebulous trying to diagnose. So when you get the AFib plus HFpEF, it becomes a little bit more obvious.
Questions from the audience? The door.
Samir and Krishna, have you guys changed your practice with Castle AF and camera MRI in terms of patients with low EFs and being more aggressive for an ablation?
We can start. That excellent question, actually. So the two things that I can see after Castle, one, the referral, the threshold for referral has changed, and I can see that clearly. Patients are being referred rather early after the Castle AF study, which was the first study to show the mortality benefit in the heart failure population. I think the practice hasn't changed for me specifically, although the wording that I've used since has changed. When I discuss this with the patients, there is guidelines recommending it. There is clearly data showing the benefit. So I've used that information to discuss with our patients. But the overall approach hasn't changed. And I think in the heart failure and EP practice, we have recognized the importance of taking these patients to approaches that maintain sinus rhythm even before the trial. So that's why the trial obviously came up. The trial was conceived in early 2000s. It took a long time to come out, but.
So briefly for me, it was a conceptual change. I used to think that those patients are too far gone because of their HFrEF to bring them back from AFib. Now this shows that there is, again, you break the vicious circle and you're in a much more beneficial place. A question from Dr. Tumalapalli. Again, thank you for your engagement, Dr. Tumalapalli. Jess, the question is, ARNIs, SGLT2 inhibitors, aldactone, diuretics, et cetera, should we try all of the above before we get the patient to AFib management?
I think we do them in simultaneous fashion. They're in parallel. I think the prevalence of AFib in heart failure just tells you that even if you maximally manage somebody, once you've had it, the odds are going to have it again are so much higher. So I do them in parallel.
Krishna, yeah.
Yeah, I just want to add to that question and Dr. Huston's comments that one thing I haven't discussed today in the presentation is the timing and the type of heart failure. And there is a sweet zone, if we can say. The earlier these patients get to the treatment, the better they do. Also, from a heart failure standpoint, the class 2, class 3 seem to do better than class 4 from an intervention standpoint. So I think addressing all that we can change from a risk factor standpoint, starting medical therapy, and also maintaining sinus rhythm early on seems to be better for these patients.
Totally agree.
One more thing too, talking about type of heart failure, we now have therapy for HFpEF. So we talk about GDMT for our HFrEF patient population, and we could debate about the use of SGLT2 inhibitors and Entresto, but there is pretty good data to get those patients, at least some groups of the patient population, HFpEF on those. So you should be doing those in simultaneous fashion with AFib management as well. So that's
AFib, low blood pressure, soft blood pressure, blood pressure 95 to 105 systolic, heart rate's 120. And you're not sure if it's the chicken or the egg. And we want to treat both. I know, it's a trick question, but in that particular situation, assuming they're on metoprolol and you're still not getting where you need to be, what would you do?
I think that's where you have to use amiodarone, for rate control, if anything, just because it's the safest thing at that point. And then simultaneously, if they have a heart rate of 120 and AFib and they're low output, I think the likelihood that you're going to improve a significant reduction in cardiac output with just controlling the AFib or getting them in sinus is quite low. So my tactic is to treat the heart failure first, really, and kind of figure out the AFib second. I realize that's, heart failure is my nail. I'm the hammer for that. So, but that's my bias. Yeah.
Thank you.
Just a quick answer to the last question we'll take from Dr. Sadi online. Is there do you go for Entresto over ARBs and ACE inhibitors in that population of HFrEF with AFib? And if not, then do you have a preferred ARB? That's the question.
I go for Entresto if I think the patient will tolerate it from the very get-go. If they have hypertension and they have enough blood pressure, I very rarely start ACE inhibitors these days, just because the 36-hour washout period for Entresto to start, it just is more clunky and complicated. So I generally start valsartan and then transition as an outpatient to Entresto instead of even bothering with lisinopril.
Perfect, perfect. Thank you all. Thank you for the speakers. That was a great session. And yeah, go ahead. And we'll regroup here exactly at 10:45, and we'll kick off the second session with Dr. Estes.